Hi, Ava. Hi, all. We'll just wait a few more minutes before we get going. So just bear with me. And we'll maybe start at 2 minutes past the hour. Thank you. Hi everyone, thanks so much for joining the webinar this week. This is the last week Richard's away on his trip. Next week we'll have Dr. Ruth Green speaking about dermopathology, so not to be missed. But I'm going to get going with today. And again, any questions, feel free to put them in the chat or the Q&A, and I will be happy to pass them on. So without further ado, thank you.
I'd like to start to talk about the WHO. Is our Bible in such sense we all have to follow it, and it's not different in bone and soft tissue. So the last classification is from 2020, which some of us here participated on, especially on bone. And it divides the tumor into benign and malignant, and as every classification of all tumors. But we have an intermediate category that is quite difficult for the oncologist to pass that information on to patients. And those tumors are either classified as locally aggressive or rarely metastasizing. So it's a category within a category in intermediate. But for the subject of today, which is nerve sheath tumors, there are very few that will fall into intermediate category, actually just one. So that's the classification, very busy, as you know. And the peripheral nerve sheath tumors are a very interesting section of the bone and soft tissue classification. And they are divided mainly in benign and malignant. We have one form of neurofibromatous tumor or atypical neurofibroma that would be classified within the intermediate category. So the format, as you have been doing, is on case presentation. So you got, I think, 7 or 8 cases to look at, which I hope you did. And we're going to go through these cases. So first thing I do when I look into a soft tissue or any tumor that is sent to us for review or our biopsy, or tumors that are biopsy here, I put these questions in my mind because spindle cell lesions can be reactive. And if you forget to ask yourself these questions in that order, it's not uncommon that you're going to miss something. So every time I'm looking at a slide, I usually do it blindly without any clinical information. This is the way I like to operate. So I always ask myself, is this a tumor? Can I exclude a reactive lesion? Can I exclude that this is a myofibroblastic proliferation that is reactive, or a nerve sheath proliferation that is reactive, like a traumatic neuroma, something like that? So always think, can I exclude a reactive lesion? Second thing, obviously, that we have to consider when looking at a case, is this really malignant? Can I exclude that this is a benign lesion with some degenerative type atypia that is simulating something malignant? And then the third question is, if I conclude it's not reactive, not benign, it is malignant, is this really a sarcoma? Can I exclude any other malignancy? So we know that sarcomas represent approximately 1% of all the cancers. So the likelihood is that the lesion you're looking at might be something else, either a melanoma or a carcinoma, even a germ cell tumor or a lymphoma stimulating a sarcoma. So we have seen examples of spindle cells simulating all these diagnostic categories. So it's very important to think, can this be something else? Let's go to the first case. So this is a 33-year-old presented with a lump at the right side of the back, thought to be a cyst, 23 millimeters in size. So that's the usual history that we get in soft tissue, a lump. Not much history, sometimes painful, sometimes not painful, sometimes the patient knocked their chin and then they found the lump, but they found the lump because they knocked their chin and not the lump was formed because of a trauma. So this is a very common type of history. So at low power, the first thing that we see is that is a well-defined nodule. So can this be reactive? Probably very unlikely to be a reactive lesion that is so well-defined and kind of encapsulated even. When you look at the cells, you can see there's some even at lowish power, some atypia or some polymorphism, let's not call it atypia, some variation in size and some nuclear hyperchromasia. The other very important thing to look when you're looking at a spindle cell lesion is the vasculature. The vessels tell you a lot. So the vessels in reactive lesion are parallel, well organized. The vessels in benign tumor are usually thicker, so with thick wall blood vessels or even hyalinized wall blood vessels. So this halo of hyaline material around the vessel suggests something more to the benign or low grade side. So you usually don't see these thick wall vessels in malignant lesions, but this is kind of worrying, no? These hyperchromatic cells. So the other thing you have to look on spindle cell lesions are the type of cell. So what kind of cell is this? Does it look like a myofibroblastic? Probably not. Myofibroblastic cells are usually more ovoid, the nuclei with inconspicuous nucleoli, which this have, but this also has some variation, some ovoid or round nuclei, and some kind of coma-shaped or wavy, like coma-shaped or wavy nuclei, like this one, which brings your attention to think that this may be a nerve sheath tumor. So wavy, coma-shaped nuclei, very like this one, like tapered in one area and not so much in others. So get the most you can from the morphology. Nowadays we tend to go to more like DNA, RNA panel, whatever. But sometimes the morphology gives you enough information for you to safely report a case. Again, if you look at this, you can see this thick hyalinized wall vessels around. That's a good sign for this tumor. With this coma-shaped nuclei, wavy nuclei that you see around one side tapering. My first working diagnosis here would be that this is a nerve sheath tumor. Obviously, I didn't put the most typical one for you because you see loads of this every day. So what you ask in this tumor, so our first line panel in spindle cell tumors are 4 markers. We don't go off doing loads of markers. We do MNF, cytokeratin, S100, SMA, and desmin. Sometimes we add a CD34 as a first line panel, right, of the tumors, and we get quite a lot of information with those. So this is diffusely positive for S100, which concurs with what we are thinking when we start analyzing the case on morphology. In this case, if I really suspect nerve sheath tumor, I frequently ask EMA also, so this delineates the perineural component around the tumor. So these tumors grow usually on the periphery of the nerve, so they are really surrounded by a layer of perineural more than, and then for the pseudocapsule or reactive fibrous tissue that we see in every tumor. So this is another case, but this is the typical histology that we see in tumor type. So obviously you already figure out that is a schwannoma, but is a slightly not the very usual schwannoma type. The usual schwannoma type that you see is that what we used to call a marble-like appearance with Anthony A areas with nuclear palisading, and Anthony B areas, which are those loose areas, and also these thick wall blood vessels that are really, really helpful. So pay attention to these. Sometimes with fibrinoid necrosis, they're constantly present in those schwannomas, on those benign nerve sheath tumors. So again, we can see the palisading of nuclei. This case is much more cellular, but the same type of degenerative type atypia is frequently present in these tumors. So the first case, the diagnosis is that of schwannoma. Schwannomas has many forms. Ancient schwannoma, so if you have a predominance of degenerative type atypia. Cellular schwannoma usually do not have those 2 areas. It's completely cellular and frequently is not, you don't see palisading, and it's usually pre-sacral in the retroperitoneum. So that's a very good place for cellular schwannoma. It's a very difficult area to cases to diagnose sometimes because it's a pitfall for sarcoma in this area. Plexiform schwannoma, frequently in the hands, so it can be congenital epithelioid schwannoma, microcystic reticular schwannoma. I'll show you a couple of cases. This is a case of a congenital plexiform schwannoma, which is very, very cellular, a bit scary actually. And this is an example of an ancient or schwannoma with degenerative change. You see this degenerative type atypia throughout, but still you can see the thick walled blood vessels around, which is very, very helpful. And if you do an S100 is diffusely positive, it's fine. You don't need to worry about this lesion. This is an intra-abdominal lump. I think it was associated to the stomach, and you can see this microcystic morphology with some epithelioid cells. This does not look like a schwannoma at first look, but this is that variant of microcystic schwannoma that usually it is intra-abdominal. But if you look in different areas and you're really careful with the morphology, you still can see those spindle cell with wavy or coma-shaped nuclei. That's with one area that's tapering that you see in any nerve sheath tumors, no? Where pointing to you that this is a tumor with Schwannin origin. And this case was S100 diffusely positive. This is an overstained case, but that allowed the diagnosis of microcystic schwannoma. So schwannoma are very common. You see a lot of them. Don't be afraid of the atypia that you see in schwannoma. Mitosis are usually not found, but 1 or 2 in cellular schwannoma can be seen, right? So the second case is that our 42-year-old lady presented with a 24-millimeter lump on the left leg, so similar history, so all about lumps that are presented superficial or deep. So this case at low power shows a post-cellular tumor. This doesn't impress much in terms of cellularity. Very well organized for a reactive lesion, so I wouldn't think of a reactive lesion. A bit storiform. Let's see more detail. So you see more fascicles. Usually in schwannoma, you don't see that many fascicles. You see that the cells are dispersed haphazardly. But again, the cells look nerve sheath, so they're coma-shaped, very thin nuclei, and it looks like they're very long cytoplasmic processes in this sample. So if you look on detail, and the stain is good, you can see that there are very long cytoplasmic processing in either side of the nuclei. And more than fibrous tissue, is not really, there's fibrous tissue around, but here, between the fibrous tissue, those are cytoplasmic processes from the tumor cells. So coma-shaped wavy nuclei, again, let's think of nerve sheath tumor. But this case is not typical for a neurofibroma and is not typical of a schwannoma. And this was EMA diffusely positive. And again, EMA stains a lot of things. It's not specific, but in the case of this tumor type, which is called soft tissue perineurioma, it stains those long cytoplasmic processes. So with this stain, you see there is very little fibrous tissue in between, which is negative for the stain. And all the fibrillary material that you see on the H&E are the cytoplasmic processes of the cell. So again, go back to histology always when you get the immuno and find what you found on the immuno, try to transpose it to the histology. So this is a perineurioma. Perineurioma is common in the lower or upper extremities and followed by the head and neck. Most of them are subcutaneous, but they can be deep. When they're deep, it's more difficult for you to think or diagnose those tumor types. We use DMA, but there are other 2 markers that can be useful if you have them in hand, Claudin 1 or GLUT1. Remember that approximately 60% of perineuriomas are CD34 positive. I should have said that schwannoma are usually negative for CD34, although some cases can be positive. And in the hands and fingers, you can have the sclerosing variant of perineurioma, which is quite fibrous and a bit different. Okay, so next case is case 3. I think we can get the questions at the end. So case 3 is a 13-year-old with a right upper thigh tumor, likely arising from the right saphenous nerve. So that you got the clinical information or the radiological information, which is useful. That is either arising from the nerve branch or from a vessel if it's another tumor type. So this is useful information. So when you look at this case, you can see there is a very cellular area in the center and is very paucicellular at the periphery. Again, if we look at the vasculature, it's dispersed around. It doesn't look like quite a reactive tissue type, but more as a tumor. And you see a lot of collagen around. But the collagen is very wavy, very, very wavy, almost following the nuclei of the cells. And I go back to the center of the lesion because it shows the origin of this tumor. When I said on the beginning that the schwannoma arises at the periphery of the nerve and bulges the nerve, so when the surgeon will resect the schwannoma, the surgeon will open the perineuro and the schwannoma will pop out, like it will be shelled out. This is not inside the nerve branches or the nerve twigs or fascicles, whereas neurofibromas, they are intraneural. They develop inside the nerve most of the time. So when you look at the cell type again, you can see these cells with wavy cytoplasm associated with this collagen, also wavy collagen bundles. And when you look at the more cellular areas, the cells are the same. There's no atypia. Some are more ovoid, more activated. The nuclei are plumper. So they're not resting as much as they are at the periphery where the nuclei are a bit shrunk. And if you look at a good H&E, you can see axon fibers within the tumor. This does not happen in schwannoma. This happens in neurofibroma because it's intraneural. It's formed within the nerve. So you can see even hidden here, you have axon fibers. You can have immunostains for that, but it's really not necessary. Again, another one here look like a spine of a fish. So you have this axon fibers within the tumor. Those tumors are S100 positive as schwannoma, but there are also CD34 positive, and I think CD34 is quite helpful in neurofibromas to differentiate them on tumors that are evolving, especially in the setting of neurofibromatosis type 1. We call that the neurofibromas, they form like a lattice-like pattern. It's a very organized pattern of lattice-like architecture within the background. So this is a neurofibroma. I'm going to talk about neurofibroma after the following case. So the following case is a 20-year-old female with an expansion on the left sacral foramen. And this is a more diffuse lesion. So you can see it's infiltrating or entrapping fat. You can see some skeletal muscle here with atrophy. You see when skeletal muscle is atrophic or in an elderly person in the back, you see a lot of fat replacement, both in histology and in the MRI is very common. And you see some Meissner-type bodies within this tumor, which is very common. When you see this, you think this patient is probably a patient with NF1, because those kind of formations are very common in neurofibromas associated with NF1. And this is a diffuse type nerve sheath tumor. The cell, if you focus on the cell, is exactly the same. Round cells, round to ovoid, to spindle cells with the wavy cytoplasm. And this is the CD30 form, or again with that lattice-like growth pattern, not worrying. So this is neurofibroma diffuse type. So neurofibroma can be conventional, and when it's in soft tissue not associated with the skin or the dermis, is usually intraneural, is an expansion of a small or medium size or even a large nerve branch. You can have plexiform neurofibroma, which is usually or almost always associated with neurofibromatosis type 1, is one of the criteria. and you form this plexiform arrangements of the tumor, but the cytology of the tumor is exactly the same of a conventional neurofibroma. And you have the diffuse type neurofibroma that can occur in the skin most frequently, but anywhere in the body, as this case in the pre-sacral or the sacral foramen. Important in relation to neurofibroma is when you start to say the neurofibroma is atypical. So remember, there are neurofibromas with degenerative type atypia. Same thing as you see in ancient schwannoma. Those tumors you shouldn't call atypical neurofibromas. They should be called neurofibroma with captured cytological atypia because they're not pre-malignant lesions. So several molecular studies have shown that those are ancient or degenerative type change. However, you have a form of intermediate or transformation of a neurofibroma in a more malignant situation, and we call this nowadays a NUB or atypical neurofibroma. This is the preferred term, atypical neurofibromatous neoplasm of uncertain biological potential, to signpost to the clinician that this might behave or might transform or might behave aggressively. And these have to be associated with NF1 because we do not assume that a regular neurofibroma, sporadic neurofibroma in a non-NF1 person has a significant chance of transforming into a malignant peripheral nerve sheath tumor. So these tumors are defined by cytological atypia, hypercellularity, loss of neurofibroma architecture. This is the most important criteria in my view, either on H&E or CD34 immunostain. So you lose that lattice-like growth pattern, and mitosis, which are usually less than 3/10 high power field. They show on molecular profiling deletion of CDKN2A and B in their locus. So this is a case where you see a neurofibroma, a typical neurofibroma, but with cytological atypia, and you start to get concerned. Is this a neurofibroma with degenerative type atypia, or is this a proper atypical neurofibroma of uncertain malignant potential? So you see this atypia, there's no mitosis, the cells, but if you abstract from there and go back to the cells are typical of a neurofibroma, wavy, coma shape, and all the things you see. There's S100 positivity, not diffused, but you can have a mixture of the cells in neurofibroma anyway. And CD34 in areas show the preserved lattice-like growth pattern, but in other areas is completely lost. So you have loss of this architectural pattern of CD34. So this is a case of an ANUB or atypical neurofibroma in a patient with NF1. So the clinician should follow up any other neurofibroma or any recurrence because there is a risk of transformation in MPNST. And if this is a biopsy, those lesions should be excised if possible. So case number 5 is let's see what I'm doing in time. I'll be quick. The 36-year-old with a 10-year history of a lump in the right shin. And this is a kind of a funny tumor, very difficult when we look at it's well defined. It's not quite reactive. There's those big vessels in between. But when you look at a higher power, you can see, it's not so high the power, but you can see some of those cells that make you think that this is a nerve sheath tumor. But equally, you see a fascicular growth pattern and some very long cells. So you kind of in between, you don't know if this is a perineurioma, but it's quite also, it's not fully arranged in fascicles. There's some cells that are haphazardly arranged. There's some coma-shaped cells. As you see in nerve sheath tumor, some a degenerative type atypia, some polymorphism, but not fully atypical. You do your regular immuno, see it's quite positive for S100, but it's also positive for EMA in that pattern of a perineurioma with very long cell prolongings. So you have a mix of both tumor types here. You see areas that look like a regular schwannoma or an nerve-shaped tumor, and areas that look like a perineurioma. And this is happening more and more. We have seen a lot of hybrid tumors. CD34 is not there, so it doesn't look like there is a neurofibroma component. So this case is a hybrid schwannoma and perineurioma, and some of these have been associated with this fusion, which was demonstrated in the case I've just shown to you. So those are rare. We see maybe 1 or 2 a year in a specialist unit. So it's very rare that you come across one of these, but you should be good if you think of a nerve-sheath tumor and you always do your S100, your EMA, and your CD34, you should think of those hybrid lesions. So moving on with something more aggressive, a 46-year-old presented with a very large left thigh mass, which was biopsy. So those are tumors that grow very fast. So very frequently they present with large tumors. So at low power, if you go back to that questions I was giving you at the beginning, can this be reactive? No, this pattern of necrosis and this pattern of cellular preservation or condensation around blood vessels is not typical of reactive lesion, nor of a benign lesion. This is very dirty necrosis, right? So when you look on detail, you see this dirty malignant type necrosis and this condensations of cells around blood vessels. But it's more than a condensation. It looks like the cells are really plugging in the wall of the blood vessels, like forming a sunburst kind of arrangement around the blood vessels, which is what we're seeing in this tumor type. Other areas of bone formation. This is not reactive bones, necrotic bone, and is also both woven bone and lace-like osteoid type deposition by the tumor cells, by the transformed tumor cells, and there's some osteoclasts around. And again, to focus on this kind of pattern around blood vessels, so the cells hanging on the wall of a blood vessels forming kind of a crown around the blood vessels. And you can see mitosis are very frequent in this tumor. So it's a malignant tumor with a lot of necrosis. But again, if you look at the cell type, you can see around this, the cells are bigger than the regular benign nerve-sheath tumor, but you can see around the kind of coma-shaped or wavy nuclei that kind of gives you a hint that this may be a nerve-sheath tumor in its essence. S100 is not diffusely positive in this lesion, and if it is, you should think of a melanoma. Oh, but it's melanA negative HNB45. Even if it's melanA negative, HNB45, a high-grade malignant spindle cell tumor with diffuse SOX10 and S100 expression, is very unlikely that we would call this MPNST. We have seen more and more undifferentiated melanomas or dedifferentiated melanomas with loss of expression of melanocytes. MPNSTs that are spindle cells are usually negative or very focally positive for S100 and SOX10. This case had complete loss of H3K27ME3. We use this more and more to confirm the diagnosis of MPNST, although it's lost in other tumor types, but it's not lost in all forms of MPNST, just the classical ones associated with neurofibromatosis or arising from a neurofibroma. They frequently have loss of H3K27ME3. So this case is a malignant peripheral nerve sheath tumor. They can have heterologous differentiation, either in the form of rhabdomyoblastic differentiation, which is the most common, and we used to call that in the past malignant Triton tumor. MPNST is a highly aggressive tumor, and they are a diagnosis of exclusion, really. There are no specific marker other than nowadays loss of H3K27ME3 expression. And The criteria for diagnosis MPNST is a sarcoma arising from a peripheral nerve, a sarcoma arising on a neurofibroma, sarcoma in a patient with MF1, and generally focal S100 or scatter S100 expression if present. If loss of H3K27ME3 is present, is very, very helpful, but it doesn't happen in all cases. All right, moving on to case number 7. So this is a very interesting case. It's a 68-year-old female who presented with a 37-millimeter tumor associated with left posterior tibial nerve. So this is a tumor arising from a nerve, which makes life much easier, but not always we have this picture in this tumor type. So when you look at low power, this is a multilobular tumor, quite infiltrative at the edge. It's bulging around, and it's very cellular. Maybe some focal necrosis here, some areas of hemorrhage there. And when you look at the cell type, it's not very pleasant to look at the cell type. It looks quite malignant. There's some mitosis around, but those are epithelioid cells with vesicular nuclei and central nucleoli. So it look like a bit like melanoma, although melanoma can look like anything. So you can see mitosis here, vesicular nuclei, central, very conspicuous big nucleoli. And these tumors are usually diffusely positive for S100 and SOX10. So then you have some differential here. You have a clear cell sarcoma, you have a malignant melanoma that you should think here, and you have an epithelioid malignant peripheral nerve sheath tumor. Epithelioid malignant peripheral nerve sheath tumors are not associated with neurofibromatosis type 1. They're tumor that occurs sporadic. This case was negative for melanate. There's an hemosiderin deposition due to hemorrhage around. Melanomas can have loss of melanate, as we said, but it's arising from a nerve, and it looks like an epithelioid MPNST to us. And most importantly, most of the epithelioid MPNSTs have loss of SMARCA1, SMARCB1, sorry, INI1. So INI1 is lost on the expression of this tumor, and if you do DNA, you have loss of SMARCB1. The DNA analysis. So INI1 is really helpful in epithelioid nerve sheath tumors, not only epithelioid malignant nerve sheath tumor, but can be lost in a subset of epithelioid schwannomas also. But this is morphologically, histologically malignant. So that's diagnosis of case number 7. So remember to think of epithelioid MPNST when you see epithelioid tumors that look like melanoma, multilobulated, but they are deep and deep-seated usually within muscle or associated with the nerve, and they have loss of INI1. So last case, and then I think we will have some time for questions if you have some. Is a 51-year-old female with lump on the left shoulder, and an excisional biopsy was performed. It was a superficial lump. So this is a very characteristic tumor. Once you see 2 or 3 of those, I don't think you miss them again. Those tumors are usually very poorly circumscribed and diffuse. There's a diffuse proliferation of those cells. You can have some inflammation and some lymphocytic aggregates at the periphery. Usually intradermal structures if it's associated with the skin. And you can see the tumor cells are really beautiful and characteristic. You see central nuclei and a very granular cytoplasm. So the cells are monomorphic and look the same with this very, very granular cytoplasm, very characteristic. There's very few things that you would think when you look at a case like this. If you want, you can do an S100 just to prove that this tumor are S100 positive or SOX10, so they should be diffusely positive. and this is very typical granular cell tumor. Remember that granular cell tumor can occur, usually occur in the dermis, deep dermis, or subcutaneous. The most frequent site is the tongue and other areas in the head and neck, trunk, but can occur in soft tissue in proximal extremities. So this case, I think, was shoulder. And there is visceral involvement. So not unfrequently you find them in the larynx or in the gastrointestinal tract. So granular cell tumor is a thing that is a nice thing to diagnose, very, very, very fast diagnosis and very easy case to diagnose once you know the tumor type. Remember that up to 10% of these cases can be multifocal. Malignancy in granular cell tumor occur, but it's very, very rare. I think we see one malignant granular cell tumor every 8 to 10 years. And to make that diagnosis, you have to have significant atypia, mitosis, necrosis, all the criteria that you use for high-grade malignant tumors, really. So with that, I think we cover most of the nursery tumors. So I want to thank you for listening to me this morning. And I'm open to any questions you may have.
Well, yeah, so it's,
Richard, to the
yeah, do you want to go through to the first one? In an exam setting, what would you expect to get a variant? Would you expect to get a variant schwannoma, like a microcystic?
No, well, I don't think I would put a microcystic schwannoma in the exam. I think you've seen this very rarely, would be a bit mean. It's something you can discuss in the differential, and you need to make this diagnosis, you need to have the panel with success 100 positive, I think.
Thank you.
Okay.
The next question is, would you get a rim of EMA in
Yes.
other nerve? Yes, okay.
Yes, you can get that in neurofibromas too, depending on how it's formed, yeah.
And in case 1, what is EMA highlighting within the lesion?
No, there's what subtype is the previous case? What previous case?
Yeah, so we don't know which the previous case
I think it's the first one. I would call a regular schwannoma. Is a schwannoma is just a bit not as typical, but it's fall within the spectrum of schwannoma. What is EMA highlight within the lesion? Oh, that's artifactual stuff. EMA is very E positive in some inflammatory cells. EMA is positive. If you don't find that that's why I highlight, if you don't find that cellular prolongings, I wouldn't bother a lot with EMA. EMA is positive in a lot of stuff. Not good, Mark.
How do you distinguish diffuse from plexiform neurofibroma?
That's a good question, because plexiform can have diffuse type areas. So you really need to correlate with the imaging. If you do not see the plexiform, if you see on a biopsy, you cannot. If it's deep on a biopsy, you cannot. But you usually see small branches of plexiform areas within the diffuse type. Then you can say it's a plexiform. If you see plexiform areas, you should call plexiform.
Thank you. If you get loss of lattice architecture, but they don't have a diagnosis of NF1, what do you call it?
Well, you shouldn't have loss of CD34 architecture in a classical neurofibroma. Then you could investigate if this is something else, really.
Okay, thank you. So a neurofibroma with scattered cells showing cytological atypia and mitoses, up to 3 by 10 high blood figures. No history of NF1. How to report those?
I would be very concerned with schwannoma with 3. I would do H3K27 and E3. Actually, we have one case here that looked like a neurofibroma, but had a couple of mitoses and a couple of atypia, and it had loss of an NF1. They rebiopsy and it was an MPNST. And all those cases that are unusual, all those situations that are unusual, you have to put a descriptive report and say, this is a difficult case with unusual features, to bring the attention to the clinician that this is unusual. In every situation in pathology, if you don't have something typical, you have to highlight that in a way that is very clear on your conclusion. That's my opinion.
Okay. I thought case 4 looked like a spindle cell lipoma. Any tips to tell them apart from a neurofibroma if mixed with fat?
Well, spindle cell lipomas, you're right in the sense that the spindle cells of the spindle cell lipoma they're quite delicate and they can be a bit wavy and they're rupy collagen. But I think the collagen of the spindle cell lipoma are much more prominent, much more rupy, right, rather than delicate of this case. And also, if you are in doubt, you do an S100. The cell shouldn't, or the spindle cell lipoma shouldn't be S100 positive. Really.
Thank you. Right, so the term atypical neurofibroma is not used anymore. Is that correct?
Well, it's used as a you can use as this similar. So if you say atypical neurofibroma, you're meaning that this has a potential. There's probably loss of CDHA and 2A and B, and this has a higher risk of malignant transformation and occurring in the setting on NF1. You shouldn't use atypical neurofibroma. You can use neurofibroma with cytological atypical. If you use, that's what you're meaning.
Okay. Would an epithelioid malignant peripheral nerve sheath tumor retain S100?
Yes,
FOX10?
I think,
okay.
yeah, I think that question was before I presented the epithelial and PNST.
Okay,
it does. It's 100% positive, whereas the regular is not.
The diagnosis for case 6?
Case 6. Okay, let me look at it. I think it was the hybrid, was it? No. Case 6 was MPNST, the high grade MPNST.
Would you have considered a palisated encapsulated neuroma for case 1?
No.
No. Okay.
No,
and in case 1, could it be NF based neurofibroma based on the H&E?
It could. Case 1 was a difficult one. I put a difficult schwannoma. It could. So you have to go around. The vessels would argue against. So you usually don't have those thick vessels in neurofibroma. So subtype is the same. I would call it schwannoma. I wouldn't call cellular. It's not really cellular. It's just schwannoma. I wouldn't class in any subtype. That myself help.
Subtype of the first case?
Yeah, I wouldn't, just schwannoma.
Okay.
I wouldn't class.
Are mast cells helpful in diagnosing neurofibroma?
Yeah, you can have mast cells, but you can have mast cells in synovial sarcoma. So we've seen synovial sarcomas, very poorly multicellular diagnosis as neurofibromas or schwannomas. We've seen quite a few of those in the past and then come back. And it's a bit of a disaster, so be careful with that.
Okay. And is S100 essential to differentiate plexiform neurofibroma from plexiform schwannoma? Or can you do it on morphology?
We usually do it on morphology, really. Yeah. And it's usually different sides. Plexiform schwannomas are usually distal extremities and, wrist. And it looks like a schwannoma, really, but within a small plexus. So we usually H&E.
So I'll take one last question and then I'll have to close it, I'm afraid, for this session.
Sorry.
So it's a long one, so I'll let you read that.
Yeah, H3K is not widely available. It is here, so send it here. We're sending it around in 3 days.
Okay.
With pleasure.
Great. Thank you so much.
Thank you. Thank you very much.
Okay, thank you very much for attending this week. Next week we have Dr. Ruth Green doing skin pathology or dermapathology, and Richard will be back from his leave. So yeah, we'll see you next week, and thank you very much for attending.